Trauma-informed care. The facility must ensure that residents who are trauma survivors receive culturally competent, trauma-informed care in accordance with professional standards of practice and accounting for residents' experiences and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. Patient-endorsed or family chart indicate a history of past trauma experience which may place the resident at risk for unintentional re-traumatization and negative emotional, physical, cognitive, behavioral reactions such as experiencing feeling anxious or fearful, avoidance of activities and social supports, refusal of care, ADLs, physical occupational therapy, irritability, anger, increased depression, anxiety, sleep disturbance, appetite disturbance, increased fatigue, or negative verbalizations. Residents who have a history of trauma and or PTSD, post-traumatic stress disorder, must receive appropriate person-centered and individualized treatment and services to meet their assessed needs. There are screening tools such as questionnaires, assessments, checklists, etc. to ensure proper information is collected in order to care for residents appropriately. Acute versus chronic trauma. Acute, usually weeks to months. They become adaptive, keeps person vigilant and reactive to danger. They can resolve as safe environment is established. However, chronic is extended period to lifelong affliction. Maladaptive stress response to everyday events, alters daily patterns, maladaptive coping responses, persistent symptoms, flashbacks, physical and emotional symptoms. They have avoidance, fear, and isolation become frequent experiences. PTSD is not exclusively a consequence of combat or war zone exposure. Individuals who have been physically or sexually assaulted, who have experienced a terrorist attack or natural disaster, among other things, may also be affected by PTSD. Some older nursing home residents may have lived through a time of genocide and witnessed or became subjected to the intentional and systematic destruction of a racial, political, or cultural group, such as that which occurred during the Holocaust in World War II. Being admitted to a SNF can cause worsening or reemergence of symptoms and trigger memories of traumatic events, and coping with these memories may be more difficult for older adults due to the structured environment. PTSD symptoms can change with age. They change in roles, functional loss, cognitive decline, environmental changes, and failure of existing coping strategies. Care planning and signs and symptoms. History of trauma, PTSD, distrust. They have fear, depressed, their anxiety, aggression, angry outbursts, tearfulness, agitation, trembling, cowering, panic attacks, withdrawals from social interaction, and changes in sleep pattern. PTSD re-experiencing, reliving the event, emotional behavior expressions of distress, outburst, irritability, discontent, inability to experience pleasure, dissociation, hyperarousal, increased startled responses, and difficulty sleeping. Care planning interventions. PTSD is associated with anxiety. Utilize aerobic and non-aerobic exercise, meditation, yoga, progressive muscle relaxation, antidepressants, psychological services, minimize or eliminate triggers, etc. Be aware of your tone of voice and body language, and approach should be calm and direct. Monitor and provide ongoing assessments as to whether the care approaches are meeting the emotional and psychosocial needs of the resident, along with reviewing and revising care plans. One example of past trauma events can be the Korean War veteran, Army, infantry, or direct combat exposure. Triggers can be loud, unexpected noises of unknown origin. Symptoms and behaviors can be persistent yelling and anxiousness. Interventions. Prevent loud noises. Utilize noise-reducing blocking devices. Put on the TV, the radio, white noise machine, earplugs. Place resident where they visually see the cause of the noise and prepare the resident in advance that loud noises will be occurring. Coping skills. They may want to drink coffee or tea, sit outside, watch TV, or listen to music. Staff responses and care approaches: explain the cause of the noise and show them approach in a calm manner. Allow residents to express their feelings. Offer noise-canceling options such as the headphones, earplugs, TV. Offer a quiet place. Encourage relaxation techniques. Provide support and reassurance of safety and security, and offer interventions and activities to increase sense of control. We also can have social service referrals, psychological services, and psychiatric support services. Another example of past trauma events can be past sexual assault, abuse. Triggers can be unannounced, unexplained touching during care activities. Staff, treatment providers touching residents without permission. Resident feeling there is insufficient privacy during the ADL care and treatment procedures. Disrobing for medical treatments, and receiving a physical examination by male providers that could be the same sex as perpetrator abuse. Symptoms and behaviors: resident refusing certain care procedures and treatments. Increased anxiety: resident report of increased somatic symptoms such as pain, fatigue, increased heart rate, shortness of breath, and increased irritability. Interventions: as always, use female direct care staff and rehabilitation staff. Ask permission to begin care for ADL care and medical treatments. Encourage and allow residents to provide self-care and hygiene care as much as functionally physically able. Use hand-over-hand technique. Offer window side of room or increased privacy. Coping skills: guided breathing, mindful meditation, prayer. Distraction: watching television, especially game shows, reading the newspaper. Staff responses and care approaches: reorient to activity, care, procedure. Explain care procedures step by step. Approach in a calm manner. Allow residents to express their feelings. Offer a quiet and private place to calm down. Encourage relaxation techniques and activities to increase sense of control. And once again, your social service referrals, psychological support services as indicated, and psychiatric services as indicated. Questions? Okay, question number 1, true or false? Anyone can experience a traumatic event. Question number 2, types of traumatic events include A, physical sexual abuse, B, natural disasters, C, wars and historical traumas, D, accident and injuries, E, significant losses, F, all of the above. Question number 3, true or false? Being transferred to a skilled nursing facility in and of itself does not constitute a potentially traumatic event. Question number 4, PTSD stands for A, physical therapy for speech disorders, B, person-centered treatment for sickness and disability, C, post-traumatic stress disorder, D, psychologically treatment for symptoms of depression. Question number 5. Core principles of trauma-informed care include A, safety and security, B, trustworthiness and dependability, C, fostering collaboration and sense of empowerment, D, all of the above. Question number 6, true or false? Re-traumatization refers to the process of re-experiencing traumatic stress as a result of a current situation that mirrors or replicates in some way the prior traumatic experiences. Question number 7, examples of potential re-traumatization triggers include A, loud noise, B, supporting sense of privacy, C, casual touches, D, offering choices, E, A, and C, F, none of the above. Question number 8, true or false? Trauma-informed care plans should be person-centered and idealized. Question number 9, staff can support trauma-informed care by A, learning a resident's history and life story, B, preventing trauma, triggers, and unintentional re-traumatization, C, approaching all residents in the same way, D, all of the above, E, A, and B, F, C only. Last question 10, trauma can negatively impact a person's A, emotions, B, physical health, C, cognition, D, behaviors, E, all of the above. Thank you.